Today, we're going to talk to you about brow lift and upper blepharoplasty. Quite a dramatic rejuvenation from a brow lift alone. No blepharoplasty was carried out at all. And the simple way to do it is to actually take your finger, look at the brow, and adjust the brow just slightly to see how it impacts the eyelid. So
you mean go like this, just lift it up slightly.
Just lift it up slightly.
And sometimes just by doing that, you can see that crowding of skin disappears.
We often have to go through the process of the patient to explain to them that some of the aging of the eyelid is not related just to the eyelid skin itself, but rather crowding of the brow, which can drop with age. This is a zone of the face which we see a lot of patients for, and they present with what's known as hooding. But there is some confusion as to which operation is appropriate for you. And today we'll discuss it so you get some more information. Hi, everyone. Welcome back to another episode of Unfiltered. Today, we're going to talk to you about brow lift and upper blepharoplasty. This is a zone of the face which we see a lot of patients for, and they present with what's known as hooding. But there is some confusion as to which operation is appropriate for you. And today we'll discuss it so you get some more information. Nancy.
Hello. So today I want to sift through the cobwebs to sort out what the difference is between upper eyelid skin, what is browlid skin, what causes the upper eyelid skin to become hooded. And I just want to clear the air because we often, and I do a lot of the consultations with patients, we see patients who come in, they say a friend of mine had an upper eyelid surgery, that's what I want. And they can go through the procedure, have it, and afterwards they're like, but I don't see much of a difference. So I want to talk about why that can happen and just clear the air about what the difference is between the brow skin, the upper eyelid skin, and what is the appropriate procedure for that portion of the face.
Sure. So when we evaluate a patient's face, we're starting at roughly the hairline, and we're evaluating everywhere from the forehead area, the periorbital area, the midface, the cheek, the jawline, and the neck. Those are kind of the areas that we specialize in surgical rejuvenation for. Focusing on the upper third of the face is integrated with the eyelids as well. So the area that patients proceed or bring them into the office is they notice some aging of the eyes, and they come in complaining of what's known as hooding, which means that their upper eyelids look crowded by extra skin. They may say that the makeup doesn't go on as nicely as it used to. There may be some redundancy or folds of skin on the upper eyelid. And the default would be, oh, okay, you're an automatic candidate for blepharoplasty. And while you may actually be a candidate for eyelid rejuvenation surgery and trimming of that skin, we often have to go through the process of the patient to explain to them that some of the aging of the eyelid is not related just to the eyelid skin itself, but rather crowding of the brow, which can drop with age, or it can even drop with Botox therapy. So we want to evaluate that area. And the simple way to do it is to actually take your finger, look at the brow, and adjust the brow just slightly to see how it impacts the eyelid. So
You mean go like this, just lift it up slightly.
Just lift it up slightly.
And sometimes just by doing that, you can see that crowding of skin disappears.
Yeah, so the crowding of skin of the upper eyelid will be impacted by moving the brow vertically. Now, if the eyebrow is already high, then obviously you don't need a brow lift, and that would be a mistake to raise it higher. This can become a factor in patients who've had permanent makeup or tattooed brows in an area of the brow which is superior vertical to where their natural eyebrow is. And then it gets even more complicated because then we may talk about repositioning the brow with a brow lift, having the eyebrow tattoo removed with PicoSure laser or one of the devices to remove tattoo, and then re-tattooing the eyebrow in its appropriate location. But that's just, again, another sort of consideration. So assuming you have not had permanent makeup or your permanent makeup is being placed where your actual eyebrow sits, then we're looking at where the eyebrow sits relative to what's known as the orbital rim. So if you take the upper orbital rim and rub your finger on your skull, and you'll feel there's sort of a rim just above your eye, and the eyebrow should be in males on that rim. And in females, it should have an arch that extends just above that rim. So we'll take our finger just above the rim and elevate the brow, specifically in females, to be just above that rim. And we'll look at the impact of that on the eyelid. If the eyelid is completely rejuvenated and the patient likes the eyebrow position, then we'll proceed by recommending a brow lift. And we can get into more details of different surgical options for brow lift. If we elevate the brow and the patient says, oh, I really don't like that, I'm not used to that, it looks a bit odd to me, then we'll counsel them on the blepharoplasty procedure alone, recognizing that the skin just below the eyebrow and above the eyelid will not be altered from the blepharoplasty procedure significantly. So they'll still likely have some heaviness in that area. Now, some people's anatomy is such that they've always had heavy brows or low brows, and they've become accustomed to that. And we may not want to necessarily alter that dramatically, as it may give them a change in their appearance that they're not used to. And that's more frequently seen in male patients than in females. So brow lifting in a male patient is sort of viewed through a different lens than brow lifting in a female. In a female, often women are trying to give their brows an elevation, either with use of Botox, makeup, tattoos, and things like that, to almost give that arch or ponytail type of pulled look. So a lot of those patients, female patients, will be amenable or open to the concept of a brow lift. Now, if the brow lift is able to achieve both things, improvement of the upper eyelid and repositioning the brow into a more favorable position, then a brow lift will be an amazing operation. If we do that, and with our analysis, we identify that there's still some hooding of the upper eyelid, then we'll recommend both a brow lift and a blepharoplasty be combined at the same time.
I thought I'd bring photos of two patients who have recently had brow lifts, so you can maybe show what the brow skin versus the eyelid skin, what that would look like. So let's take this patient for example.
Right. So in this particular case, the patient had presented for consideration of eyelid rejuvenation. And you can see she has the standard or typical hooding of the upper eyelids, crowding the upper eyelids, so you can't even see the actual, what's known as the tarsal plate or the tarsal platform, which is the area you place your makeup. So there's no platform visible. There's rather just some redundant skin. So we went over exactly what we just talked about. But if you look just vertical to that, underneath her brow, you can see there's a lot of extra redundant thick skin that's hanging down over her orbital bone. And so for that reason, we discussed possible blepharoplasty or brow lifting or a combination. When I elevated her brow with my finger, as described, she felt that it fully opened up her eyes and did not need a blepharoplasty. So we proceeded with a open brow lift, and you can see these are early results, but her brows are repositioned and it opened up her eyes dramatically. So it's going to soften and settle in a little bit, but this, I believe, these photos were within the first week or two of surgery. So brow lift, perfect candidate, rejuvenated the upper third of her face nicely, and was able to achieve both an enhancement of her upper eyelids without a blepharoplasty surgery at all.
And then let's take a look at this picture. This patient's concerns, do you recall?
Okay, so in this second case here, you can see a patient who'd presented for consideration of eyelid rejuvenation, but her main concern almost exclusively related to her low brow. So her brows are sitting at or below the orbital rim, and they're giving her a bit of a tired or angry look. And so she says she's always been like this since she's a kid. So we offered her a brow lift, and I felt that a brow lift would rejuvenate and enhance and change her upper third of her face, make it much more alive, awake, and more youthful. And so here she is a few weeks after surgery, and some of these are on our website, I think. So you can see, you can zoom in on them closer on the website, but quite a dramatic rejuvenation from a brow lift alone. No blepharoplasty was carried out at all. And if you look at her upper eyelid, or again, that tarsal platform, it's completely cleaned up, even though the eyelids have not been operated on at all.
So I have a question for you, going back to this patient. What if she came in and she said to you, I'm not interested in a brow lift. It's just too much. It's more than I want to spend, more than I want to take on. Would you have done an upper blepharoplasty on her, and what would it have achieved?
So an upper blepharoplasty in isolation, if I know a patient's never going to commit towards a brow lift, is going to improve that area a little bit, but it does have some limitations because some of the heavier skin from the infrabrow area is still going to be providing some crowding. So you can improve the tarsal platform, hopefully significantly enough that they have a little bit of opening up. We're just limited in what we can do through that operation because we're not able to reposition the brow significantly from the eyelid operation or an eyelid incision.
What I find interesting, we could see 10 patients, 8 of whom want to come in and talk about a facelift, 2 of whom who want to come in and talk about, let's say, their upper eyes. I'm just throwing numbers out here. It's not necessarily accurate. But women are far more open to having this incision all the way from like in front of their face, behind their neck for the facelift. But when you talk about the possibility of a brow lift, they are less open-minded to that procedure. Why do you think that is?
Again, I don't know if your analysis is 100% accurate. I'm reflecting on I'm reflecting on it on my own. I think patients are most accepting of a blepharoplasty operation.
That's an easy sell.
It's a smaller procedure,
yes.
and it can be done.
They can wrap their head around it.
Right. So it's a local anesthetic, smaller procedure, quick recovery, and limited downtime. So blepharoplasty for sure is sort of an easier thing for many patients to consider, and probably is, I would say, sort of like dipping your toe into the aesthetic surgery world. So eyelid rejuvenation is probably one of the first things people consider doing. Then they start noticing areas of aging along the jawline, neck. Frequently, those patients have gone and spent thousands of dollars on other non-surgical devices before they see us because they're really scared of the surgery in general. But once they've reached a decision that the non-surgical devices have had limited upside, many of them sort of make that leap of faith to come see us and consider surgery. Brow lift, I think, is just something that patients may not have quite the same awareness of. And even though it can be one of the most impactful and significant aesthetic procedures that we offer, it may be that patients aren't even bothered by it. They're not really aware of it. Some of the patients that we see who don't want to even consider a brow lift are people who've done Botox and wear bangs. So if you wear your hairstyle that camouflages the upper third of your face, you're not going to really be looking or zooming in on that. And if the Botox makes your brow look smooth, which it does a really good job on, you may think, hey, I've already treated my brow. It's ideally toxed or improved with toxin, which is going to be smoother, but the position of the brow may be low, and the crowding of the eyes, they're attributing to the eyes, not the brow. So it's about education, I think, that people don't really go that way. Whereas on the lower part of the face, it's almost like there's only one solution, which is a facelift. Whereas the upper third, there's non-surgical solutions such as Botox primarily, then blepharoplasty, and then the third most common would be brow lift.
So a common hesitation for patients when they learn, okay, it's not an upper eyelid surgery, it's a brow lift surgery. They, when you start repositioning the brow and you're holding it up, and sometimes I can see in their faces, they get a little reluctant or hesitant. They're like, I don't want to look surprised. So how do you dispel that fear that they will wind up looking permanently, surprised?
Right. No, it's a good question. I think in general, our work speaks for itself. I mean, we've got hundreds of examples of patients who've had brow lifts that don't look surprised. So hopefully that gives patients some confidence. But in general, we want to be on the conservative side of things, giving them a result, but not obviously overdoing it. Respecting patients' anatomy, knowing sort of the ideal position of the brow. These are all things that we're educated on and come into practice. There are different brow lift techniques, which we can talk about. And I think some of the techniques are more able to customize than some of the other brow lift techniques. And I think just like everything else, if a technique is adopted by every surgeon, sometimes it may be over-offered, and maybe some patients who weren't great candidates for the procedure may have had a brow lift that may make them look a little bit overly done or overly surprised. The good news is that many of these procedures are somewhat reversible. So if a patient were to have an over-elevated brow, there are ways for us to bring the brow down a little bit as well. But maybe we want to talk about, or you can ask me a little bit about the different brow lift techniques.
Sure. Well, the pictures that we just shared, those were open brow lifts.
Correct.
So I'll just pull it up again. You can show what the incision is. The placement for the open brow lift is from here to here along the hairline, right?
Yeah, so an open brow lift means that there's a single incision that it goes across the brow. I mean, there's different open brow lifts, believe it or not. There's brow lifts, and we perform them very rarely on certain patients, often males who are bald. And that's we can talk about that as well. Considerations for brow lift in men is different than women, just due to the patient's or male's potential future hair loss. So there's going to be visible scars if a guy loses his hair down the road. So one brow lift is a direct brow lift right on the eyebrow. So the scar's hidden on the eyebrow, and that's actually a powerful technique, and we generally use that on men. The best candidates for that are aging. Men are a little bit older, 60s and up, sometimes a little bit younger than that. If they have bushy eyebrows, it's good. So you can camouflage and hide the scar. Then there's something called a mid-brow lift, which you make the incision staggered literally right in the middle of the forehead. That's really only ideal in someone who's got deep wrinkles in their forehead. So they have significant, often solar damage, wrinkles on their forehead, and you can actually hide the scars. Usually it's often a patient with very light skin with photo damage. Then the more common procedures are the incisions are made right at the hairline or within the hairline. And then the final one is called an endoscopic or minimal incision brow lift, which can involve either 3 to 5 incisions that are more limited in size and hidden within the hairline that require no removal of tissue, but just repositioning of the scalp. So in terms of the open brow lift, what these two patients had, in my opinion, and some surgeons only do one technique or the other, I generally will choose a patient or offer the procedure in a patient who has a long forehead. So we don't want to necessarily be rotating their forehead back and making their forehead look even longer. And we're going to be doing the incision in the hairline, right at the hairline in a wavy pattern, and then extending back into the hair. So about 2/3 of the scar is hidden within the hair. And then the central third, maybe right at the hairline. We do it in a way that the hair follicles are left intact. We sort of make the incision in a way that we're not violating the hair follicles. And then new hairs hopefully will grow through the incision site over time to hide and camouflage the scar as well. I'd say that the hairline incision, open brow lift, the patient satisfaction is extremely high. The ability to reshape the brow and reposition the brow rather than just move it in one vector is more flexible, is most flexible because you've actually elevated the entire brow and can reposition things in the most comprehensive and flexible manner. And so for an older patient with a long brow, that's my better procedure. In a younger patient with a long forehead with very low brows, I worry that the endoscopic brow may not achieve the results that they want.
So the open brow does the lateral and the central brow.
Yeah,
Does it all, lifts it all.
it does it all.
The endo brow, more lateral, a little central. Is that correct?
Yeah, I think in general terms that's true. So there's sort of two types of endoscopic brow lifts. There's based on the number of incisions. So the classic one would involve 5 incisions. So we're going to make a small incision in the hair just above the apex of the eyebrow. Another one laterally, where you're going to get a lateral pull. And so that's going to help with the lateral aspect of the brow. Then another incision centrally, and then again another one at the apex, and then another one lateral. So you've got 5 small incisions. They're all hidden in the hairline, which is the appeal of the procedure. And then you're going to be fixating the scalp in a new position with sutures laterally, deep sutures internally to pull everything up laterally. And then often we use bone-anchored devices to hold the brow above the apex of the eyebrow at another point. So you've got a lateral pull, a vertical pull, and then centrally is primarily for access or some elevation. That operation is amazing in someone who's got a relatively short forehead where the access point is close, where the hair is closer to the area that we're trying to elevate. In someone with a long forehead, it's going to be rotating things back, as I mentioned before, which may not be ideal. And also you may have failures of the operation, whereas you undergo the procedure and it doesn't hold up because you're relying on sutures and then scarification of the tissue into its new favorable position, but there's no removal of tissue. So again, open brow lift, older patient or long brow patients, most effective, most flexible, in my opinion. Younger patient, shorter forehead, endoscopic or limited incision brow lift is ideal.
How long will the results last? Will the open brow lift, the position of the brows, will they stay there for the next 20 years?
Well, the open brow lift, you're actually removing about 1 inch of tissue across the entire forehead. So I think those hold up the best, but different doctors will have different opinions. Some doctors only do limited incision endoscopic procedures and think that open brow lifts are outdated, whereas many surgeons who perform open brow lifts feel that those are more, have better longevity.
All right, so what if a patient is insisting, I do not want a brow lift, I just want to address my upper eyelids, that's all I can afford and all I want to do? How do you manage that?
Well, if they're felt to be a candidate for an upper blepharoplasty, we will obviously be willing to proceed with the operation, but it's critical that they're educated, which we do our best possible consultation to explain to them what the blepharoplasty is hopefully going to achieve and what it may not achieve. That being said, we do occasionally still run into a situation where we proceed with a blepharoplasty. And all my patients that I see for blepharoplasty, I discuss possible brow lift. Some surgeons will not operate on a patient unless they agree to a brow lift and a blepharoplasty and fat grafting. They just won't do it because they feel like they're tying their hands. We don't do that, but it is sort of interesting that some people have that approach because they just don't want to get into like a dissatisfied patient. So if a patient's reasonable and they seem educated and they seem to understand the procedure at hand and what they've consented to, we'll proceed with the blepharoplasty. In the rare circumstance that they come back and they say, you know what, I feel like it helped a little bit, but I still feel like there's some hooding, then again, we'll lift the brow. Frequently, we'll lift the brow with our fingers and there's no hooding left on the eyelid. And this becomes a bit of a dilemma because they actually anatomically have been perfectly treated with their blepharoplasty and actually require a brow lift. Then we have to have a second conversation reviewing the indication of brow lift. I'd say about half of the patient at that point may feel comfortable proceeding with a brow lift. If the patient just says, I'm not ever going to have a brow lift and I'm committing to it, we'll consider potentially taking a sliver, a little bit more skin from the upper blepharoplasty, letting them realize, though, that they may be burning a future bridge of doing a brow lift because they could develop what's known, something known as medically lag ophthalmos, which means inability to close your eyes. Because if we go back and take more skin on their upper eyelid and then do a brow lift later, they literally may not have enough skin to do the brow lift. So we have to explain it to the patients and hopefully they're educated and reasonable and so on. Frequently also we'll show before and after photos, and while they may think it didn't do anything, they'll often see sort of the distance from the lash line up to the tarsal plate will be far more visible than it was pre-op. And then some people saying, oh, I didn't realize how bad I was to start with.
So we've been talking and focusing mostly on women. What do you do about men? Let's say you see 10 male patients who all feel they have excess skin on the upper eyelids. How many of those patients, is it the result of a brow position or is it excess skin? And how do you manage it when it is a brow lift situation on, let's say, somebody in their 50s?
I'd say that brow lifting is less common in the male patient population in general, partially due to the fact that we worry about them losing hair as they get older and the scar placement. Not all men want to have a brow lift with the incisions on their upper eyebrows because they worry about visibility of the scar. So then we're sort of in a more isolated, limited, practical approach to eyelid rejuvenation. And I'd say more male patients than females will do upper eyelid surgery in isolation, recognizing that a relatively low brow may be manly and masculine and things like that. And we don't want to don't want to feminize the brow by lifting the brows too high. The commonest scenario where we do both a brow lift and a blepharoplasty is if someone's got severe upper eyelid excess and hooding, and we just feel that some form of brow elevation is going to be necessary to give them a result that'll be satisfactory. And those are usually patients in their late 60s to 70s with lighter skin, and we'll do a direct brow lift in those patients combined with an upper blepharoplasty.
And how do you avoid feminizing an upper eyelid of a man?
It's conservative treatment. So more conservative skin excision, almost no muscle removal, limited fat trimming or repositioning. Sometimes fat grafting can be helpful to restore some of the anatomical changes that aren't skin related. So while your eye ages, it's not only the skin that we see the skin that's redundant, but part of the reason the skin's redundant is there's actually been some bony resorption of the orbit. And as the bony resorption of the orbit, the eye may sink in a little bit. Some of the skin may appear redundant and some fat loss may occur around the orbit. We often see it in the lower eyelids with a hollow known as the tear trough, which we may consider fat grafting. I know we're talking about upper eyelids, but fat grafting, but similarly in a male patient, if they have a skin excision here, they may end up skeletonizing the upper eyelids, which is a common scenario where you've changed one deformity for another. They look a bit surgerized or operated on. And in those cases, we may suggest consideration of upper eyelid fat grafting. So they'll have a little bit of skin removed and a little bit of fat put just along the orbital rim to avoid the orbit looking hollow. Okay, well, I think we covered a lot of territory there on a relatively important topic that we deal with on a day-to-day basis. I hope that was informative to you as the listener. And thanks so much for taking the time to tune in. And we'll see you again on the next episode of Unfiltered.